It gives me great pleasure to introduce our fourth and final speaker for tonight, Professor Andrew Peitzman. Professor Peitzman is the current Executive Vice Chair and Vice Chair for Clinical Services at the University of Pittsburgh Medical Center. He is the Distinguished Professor of Surgery and the Mark Ravitch Chair in Surgery at UPMC. He is the Chief Division of General Surgery and Vice President for Trauma and Surgical Services, and he is the main author of the Trauma Manual, Trauma and Acute Care Surgery. It gives me great pleasure to introduce Professor Peitzman, who will be speaking on the future of trauma and injury care, a historical perspective. Professor Peitzman.
So I've enjoyed the morning or evening, depending on where you are, very much. And again, thank you to Dr. Dela Cruz and Dr. Turk for inviting me. My assignment is talking about the future of trauma care based on historical perspective. And I'm really going to focus on the future of trauma care and actually begin the past discussion in the 1960s. So the original trauma centers in the United States began in the 1960s, and it was not by design, it was in response to the gun violence that occurred in our major cities. And the other interesting observation is each of these hospitals was a public county hospital. None of the private hospitals had any involvement in trauma care for many years, but these were the initial trauma centers, all very well known and all performing at a very high level. The real inflection point in trauma care in our country was this paper, The Accidental Death and Disability, Trauma and Neglected Disease, from 1966, which documented 100,000 deaths from motor vehicle crashes, the long-term disability, the temporary disability, the cost to the society, and no standards, no trauma care. These patients simply were out there and completely neglected. And in response, the government created a Highway Safety Act. They developed standards for EMS services, for what was required on an ambulance, how to train a medic or a paramedic. They developed communication systems, and it was the birth of the American Trauma Society. So this was the response to that white paper. Obviously, other critical steps along the way, ATLS, training doctors, the basics of trauma care, and we've all been actively involved in that. And then the optimal resources document for trauma care, which really has been the template for all of us around the world. So these were critical steps in the development of our trauma care. This is a figure that we've all seen from Don Trunke that shows the trimodal distribution of death after injury, with 50% of the deaths being immediate from head injury and blood loss, 30% early organ failure, and 10 to 15% late sepsis and organ failure. And what is really fascinating is with our trauma care systems, we've eliminated that late peak. It is a rare patient who dies weeks into their course now, and trauma deaths occur now early, again, from head injury or blood loss, or from early organ failure. So we've changed the natural history of the disease. Another important paper from the Institute of Medicine was working toward zero preventable deaths. This was published in 2016 and really endorsed continued cooperation between the military and civilian trauma systems. They recommended building a national trauma system, developing extensive research funding for trauma, maturing our trauma systems, bringing sophisticated care to the pre-hospital arena, and tourniquets were part of that, and then eliminating preventable deaths. And hemorrhage was a major cause for that. Over the past 2 decades, what we have accomplished is true maturation of trauma systems. It expedites care of our trauma patients to source control, hemorrhage control. Damage control has been a major step, and then the one-to-one-to-one blood resuscitation. So these are the recent changes in our trauma care. Let's talk about death from bleeding for a minute. So this is well documented that from the time the patient hits the front door, if they're going to bleed to death, the average time is 1.65 hours. So if a trauma patient is going to bleed to death when they enter our trauma center, that window of opportunity is quite short. But a sad observation, if you look at data on trauma laparotomy for patients who are hypotensive, it's really not changed in 20 years. In one paper from Feliciano showed as their trauma system got improved and they expedited delivery of trauma care in those patients, mortality went up because sicker patients were surviving that short period of time to get to the hospital. But we've not changed the mortality in the hypotensive patient who needs a laparotomy in 20 years. So the important observation and where we need to change how we think about this is speed to definitive care is necessary, but is not sufficient to save patients tomorrow who we can't save today. It's more complicated than that. And in continuing that discussion, let's go to the pre-hospital arena where 40% of trauma deaths occur. And we really haven't focused on that in most of our research. Of the trauma deaths who occur pre-hospital, most are from hemorrhage and a substantial portion are preventable. So many of our preventable deaths actually occur in the pre-hospital arena, not after they hit the front door. Preventable death in a mature trauma center is very unusual. And this is a study that has completely changed how we think about delivery of trauma care. It looked at trauma patients who bled to death in the state of Pennsylvania, assuming that they were not dead at the scene, and what the LD50 was, what the average time was if a patient bled to death. And for penetrating trauma from the time of injury until they had bled to death, the LD50 was 43 minutes, not from the time we see the patient, but from the time of injury. And for blunt trauma, it was 70 minutes. So if you put that into the continuum of care in our trauma delivery, we have very little time to try to salvage that patient, particularly with a penetrating injury. So how we should treat the patient in hemorrhagic shock, if the bleeding can be controlled at the scene, meaning a tourniquet or direct pressure for junctional injuries, EMS should do that. If they can't, meaning it's truncal hemorrhage, then that is a scoop and run situation. So this is a trauma room after a gunshot wound to the inferior vena cava. And the question I would ask, did this patient need crystalloid resuscitation? And the answer is no. And we now know that crystalloid is harmful, and the more crystalloid our patients receive, the higher the mortality. Red cells carry oxygen, crystalloid does not. And this has been really emphasized over the past 10 years. We know they need blood, they need plasma, and again, the genesis of the 1-to-1-to-1 transfusion that we've all practiced for about 10 years now at this point. This is a figure we've all seen of the deadly triad, the bloody vicious cycle, if you will, of hypothermia, coagulopathy, acidosis. We have to break this cycle in our trauma patients, or ideally avoid it by effective treatment and resuscitation of the patient. And we all know that when the patient is admitted with any one of these values being abnormal, the mortality increases. So until very recently, we thought that coagulopathy in our trauma patients was predominantly due to hemodilution and consumption of coagulation factors. And we now know that a large component is as a result of the injury, what we call acute traumatic coagulopathy. And 25% of our patients are coagulopathic when they hit the front door of the hospital. So now we discuss trauma-induced coagulopathy that addresses all of the components of what our patients go through. And again, we've completely rethought how we evaluate these patients and how we treat these patients. So in attempting to address the issue of coagulopathy, this is a prospective randomized study in hypotensive trauma patients who were transported by helicopter and received 2 units of FFP during their transport. And in this prospective randomized study, what we learned, there was a 30% reduction in 30-day mortality in patients receiving fresh frozen plasma, especially those patients with traumatic brain injury. We did a secondary analysis. These patients fell into 4 resuscitation groups, if you will. One that received crystalloid, one that received FFP, the third received red cells, and the fourth received red cells and fresh frozen plasma. And we see significant differences in the outcome. If we use the crystalloid group only as a reference group, we see that those patients receiving red cells, the odds ratio 0.68 for mortality. If they received fresh frozen plasma, it's 0.57. And if they received red cells and plasma, then the mortality was a third of the crystalloid only group. So the next question is why? Is that simply a change in hemostasis and correcting the coagulopathy? And the answer is no. One of the major factors was an immunologic effect. And one of the other areas of intense research now is this idea of shock-induced endotheliopathy, where as a response to the injury, the endothelium is damaged, there's capillary leakage, and the microvascular changes are a major component of what occurs in our trauma patients. And we looked at biomarker analysis from these patients who received the fresh frozen plasma, and what you find is plasma changes the biomarker expression. And the patients clustered in basically 2 groups. One group responded with a decreased mortality and increased survivorship, those in response to plasma, and those patients who did not. And what separated the groups was degree of injury. So the severely injured patients benefited from plasma. Those who were not as severely injured, we did not see the same impact of plasma. So pre-hospital plasma ameliorates the immune dysfunction after injury. Plasma was effective in the severely injured, and also fascinating and not yet explained, it works in blunt but not penetrating trauma mechanisms. So the current concepts that we have already established and agreed upon is speed to definitive care. We know that that alone is not going to change the long-term outcome. Damage control resuscitation with one-to-one components. We're just beginning to better understand the trauma-induced coagulopathy, but in the future, I think what we're going to see is that we will be able to modify the immunologic response to injury. We'll be able to minimize the endothelial injury and trauma from the time we first see those patients, and it essentially is precision medicine, because we're going to treat the patient based on their biomarker response and their genotypic makeup and change the trajectory of that particular trauma patient. So do we think we'll be able to do that? Will we change the risk of living or dying and change the risk of acute MODS? And the answer is, I think yes. And what we see here, this is based on genotypes. Patients fall into 4 clusters based on their genotype, with significant differences in the risk of developing multiple organ failure. And one other interesting observation is patients are genotypically either shock resistant or shock sensitive. And we can put any one of us on a treadmill right now and test this and find out whether you are shock sensitive or shock resistant simply from looking at your genotype. So this concept and these data are now available. We talked about hemorrhage as a major cause of death, also traumatic brain injury, and we're making similar observations with traumatic brain injury, where genetic variants and biomarkers dictate the likelihood of progression of a mass lesion in an injured patient. Completely new understanding of what we see, with an opportunity to, again, maybe change the trajectory of what would have happened in our trauma patient. So to summarize, What we know now and what we do is early hemorrhage control, hypotensive resuscitation, minimize crystalloid, early infusion of blood products. To save patients tomorrow, I think what we will be doing is modifying the immunologic response to injury, minimize the endothelial injury and trauma, and change the trajectory of the severely injured patient. Again, thank you so much for inviting me to speak today. It's been an honor.